Hello everyone. Welcome to our session on digital health and global oncology. It's my pleasure to be representing the planning committee, which included Dr. Spence from Dalhousie University and Dr. Gospodarovich from University of Toronto. Without their vision and guidance, in Laura Carson and Scott Berry's support, this session would not be possible. I know you're all eager for this session, so let's move on today's plan. The session will include a keynote lecture that will be followed by a panel discussion. I will introduce all the speakers of our session now. Our keynote speaker will be Dr. David Jaffray. Dr. Jaffray is the Senior Vice President and Chief Technology and Digital Officer at the University of Texas MD Anderson Cancer Center. He also serves as a professor of radiation physics with a dual appointment as a professor of imaging physics. Dr. Jaffray is a world-distinguished expert in digital transformation and innovation in healthcare. For our panel, we'll have Dr. Jaffray and 4 international experts, Dr. Aggarwal, who is a consultant clinical oncologist at the Guy St. Thomas NHS Trust and associate professor at the London School of Hygiene and Tropical Medicine, London, United Kingdom, Dr. Spence, who is an assistant professor in minimally invasive surgery and surgical oncology at the Dalhousie University, Canada, Dr. Lasebikan, clinical oncologist and clinical investigator in radiation oncology and clinical oncology at the University of Nigeria, Teaching Hospital Enugu, Nigeria. And finally, Dr. Berlin, a staff clinician scientist, radiation oncologist at the Princess Margaret Cancer Center and medical director of the Cancer Digital Intelligence Pillar. I invite you to check the workshop website for learning more about our speakers and panelists' outstanding careers and accomplishments. I also encourage everyone to participate and send and post your questions. Without further ado, I would like to invite Dr. Jaffray to join the stage. David, the floor is yours.
Thanks, Fabio. It's fantastic to be here. I'm just going to share my slides with you. Can you see the slides?
Yep.
Well, it's a real pleasure to be here. I've enjoyed the conference earlier this morning as well, and the dialogue. I'm looking forward to the panel discussion. This is an exciting topic, digital health in global oncology. I'm going to share a perspective with you. I see it as an optimistic perspective, but I think it's real, and so I'm really enthusiastic to see how the conversation goes over the course of this. Just going to advance my next slide. Several people I'd like to acknowledge who have contributed to some of the ideas and concepts I've presented here, and a really fantastic report from the World Bank on data for better lives, just talking about the impact of data on how our lives will be shaped into the future. We're at a point in time of unprecedented growth in technological capacity, and this is recognized. World Economic Forum highlighted this as the 4th industrial revolution in terms of its velocity, its scope, its impact on everything in our lives, and highlighted in this graphic by Gerd, just demonstrate that technology is exponential, but humans are not. And the technology is really blurring the lines between digital, physical, and biological worlds. And as we all struggle with the challenge on addressing the global need for cancer worldwide, I really am curious about how this rapid technological advances will change the landscape of the global cancer challenge. And I think it's going to be impactful, but maybe not in the way we all necessarily think. This graphic is something that resonates with me. It highlights sort of 2 perspectives. And I'm someone who's done a lot of work in building technologies to help improve the precision of care in the context of radiation oncology or other domains. And at the same time, I've worked in the global cancer community, trying to understand how we can take these technologies to the rest of the planet. And I'm sure many people here around this meeting struggle in this way. And in many ways, for me, it felt like 2 worlds. One, where we're trying to go from A to B to improve the personalization of current practices. And then in another dimension, going from A to C, where we're trying to take those innovations and move them to the rest of the planet. And what is very clear is that that's not necessarily the way the world's going to be in the future. It's very much going to be a shift from not just A to B or A to C, but I think with digitalization and the adoption of digital approaches and the increased sharing of information, we're really going to start to move on a direction that's much more A to D and much more holistic, much less of a push And that direction is really going to see us shift towards an integrated view that's technology enabled and data driven. And moving along the diagonal requires a data driven approach that is innovative, disrupts existing paradigms, focuses on local measures of value for global impact, less about push, less about teaching or exporting. And it leverages emerging trends like low cost connectivity, individual engagement, sensing, large-scale simulations of the impact of our work, and the development of sort of a global fabric for healthcare as a service. And I'll unpack some of these in the next several slides. Central to this is this massive increase in the growth of data. You can argue, and I don't think I can find anything that will debate this, maybe during the discussion, but nothing is growing faster in the world than data. And this is drawn from that World Bank report just released earlier this year, just demonstrating not only the growth in data-driven services compared to other traditional services, but also the global digital data flow. This only goes to 2017, 2018, doesn't even include the impact of the pandemic on the flow of data. And the realization that I'm coming to is that it's actually the flow of data that will carve our future social landscapes, much like water flowing across the surface of a continent cuts the location of rivers. I believe that it's the flow of data that's going to be most critical in our social landscape as well. And we're seeing it from the FANGs and other things like these, but fundamentally, I'm really interested in how this affects the strategies for addressing the global needs from a cancer perspective. And this is highlighted further in that World Bank report, the link between this production of data, its collection, and the drive towards insight extraction and how that then drives policy. And this is not a new concept. Demonstrated back in the 1800s in England, the work of Roundtree exploring and measuring and observing, and some 46,000 individuals back then that really set the line on the definition of poverty, the poverty cycle, helped inform the minimum wage. And I think we're at a point in time where connectivity and data collection and engagement by individuals is shifting to a new approach where the flow of that data has a substantial impact to shape healthcare systems and shape how we respond to burden and need in the context, for example, of cancer. And this really moves us to this paradigm, a number of dimensions along that diagonal. I call it the data-driven world. And I just want to demonstrate a whole bunch of shifts that are all, I think, stacking up to reinforce that diagonal. First of all is this extreme connectivity and the personal data management paradigm. We're seeing, for example, in the United States, the US Cures Act requiring hospitals to push information out without delay from the healthcare systems, put it in the hands of individuals. We're seeing in the scientific domain, the adoption of paradigms like FAIR principles. So data can be found, it can be accessed, has to be interoperable, this growing capacity to exchange information. Even the use of technologies like blockchain to give consent mechanisms where individual citizens are fully engaged in the use of their data if they so choose to. And it's not just going to be in the developed nations. The development of high-speed connectivity with things like the low Earth orbit satellites such as Starlink is going to make access something that's feasible and much less asymmetric than it currently is today. This is highlighted also in that World Bank report where they see the traditional data sources, the data sources of sort of public intent, the census, national counts, household surveys, and the private intent data, which used to be really about healthcare systems or private entities or financial accounts. There's an entirely new domain of both the public intent data and the private intent data. So location data for satellite imaging, digital identification, information that can facilitate understanding of social determinants, but also just-in-time digital data on individual behavior, choices, and the control of that information by individuals. And this is enabled by just a massive drop in the cost of measurement, sensing, the automated collection of contextualizing metadata. So if you capture a picture, you also know where it was captured, who captured it in the context, and the technologies that are coming to allow us to govern the use of data. And we've all seen this fairly recently with the new controls that are coming through on our browsers, which allow us to say, no, you cannot use those cookies for anything you want. You need to use them for the purpose that I allow you to. So the technology is coming, and it creates a much more democratized paradigm on the use of data. Now, like you could argue this is just sort of, for the social media world, this is not really going to come into healthcare. But a really interesting article by Marcel Salate on digital epidemiology, what is it and where is it going, just highlights the idea that we're going to start to use data that's completely from outside public health systems to start to fully inform the nature of how we respond to health needs. In the context of cancer, this is very exciting. I think we saw it in the pandemic. On the top right is the app from called the Zoe app. Some 4.7 million individuals contributed information to their response to COVID and their experience. Several healthcare organizations have also now tried to tap into that data, where individuals could register their personal data and link it to healthcare organizations for which they are involved. And you may argue that this is not going to get taken up by a recent report highlighting the growing up in a digital world, the 2020 report, is 23,000 children in 176 countries, and 88% of children and youth use digital technologies to support their health and well-being. So this fabric where we're collecting information that's representative of the experience of individuals, I think very much is the future. How they choose to share it to inform policy needs, investment is something to be seen, but I'm sure it will emerge. So that paradigm is coming. There's also this one data-driven world paradigm is really person-centered health, but it extends to value-based care concept. So we're really starting to stitch that together from a social engagement paradigm, sort of systems thinking to how to respond to this information shared by multiple individuals in the design of a health supply chain, per Julio Frank. And then going beyond not just the projected value of care, but what does care mean to the individual? As highlighted in an article by LeBlanc in 2017, that value-based care measured for the individual, not our projection of what good health is, but rather scoring it more directly for the individual using the technologies like the Zoe app or highlighted in the Digital Future article. And this, of course, will be supported by digital identity technologies that link experience, care, outcomes, cost, and satisfaction across traditional sectors. So an identity for individuals that cut across those paradigms. It's going to be interesting because it's not clear that governments are going to be focused on this. There's some suggestion. This is Edelman is a very strong PR company, does a very careful analysis of how organizations are understood. They're seeing that industry is actually becoming more trusted than government organizations. And I think this is going to be very interesting moving forward. Maybe Apple will be the vehicle by which we share this information, for example, not that I'm a great supporter of Apple. And this is so different. I want to highlight this is so different from the current way we think about rolling up data in cancer. The cancer registry paradigm, are we seeing urgency from that paradigm? The first registry was in 1728 in the General Census of Cancer in London. Finally, in 1971, the National Act in the US, and even IARC now in 2018, 1 in 3 countries are collecting high quality incidence data. And just contrast that against where we are today in the domain, for example, in COVID. And I'm sure many of you recognize this screenshot. This website was stood up by Laura Gardner at Johns Hopkins University, built this very quickly in January, had it up and running. The data flowing into this was coming from Google shared sheets from around the planet. That's the data we were all watching. And it grew and demonstrated the urgency, data, insight to urgency. And I would argue the past 2 years have changed our perspective on data dramatically. Being data-driven has taken on an entirely new meaning. And it's the flow of that data that I think will shape the landscape of society and healthcare forward. And trying to understand what that means for cancer services and how we respond, I think is very, very interesting. It's remarkable. One disease can transform the way we think of health and healthcare. And going beyond just those measures that we saw in the registry, incidence, deaths, onto something much deeper. This is Chris Wild's article on capturing cancer burden, going beyond societal to individual urgency. And I think that has the opportunity to compel investment, to compel responsiveness, to measure real value in our interventions, and drive appropriate effort. That's moving along that diagonal in a way that's not us pushing paradigm, but rather pulled by individual need and expression of the need to address burden. I think this is extremely compelling, and there's good reason to reevaluate how we measure burden of disease and predictive cancer. On that same one data-driven world diagonal, there are other things that are happening. Global, personal, and societal sensors. Topol argues that the personal investment and measurement of health and wellness data will easily overcome healthcare-based measurement of outcomes. The ability to adopt these and support these highlighted in the digital health paradigm that I spoke to earlier. And furthermore, building on top of this, the tracing technologies of COVID-19 that were highlighted, the potential to sense the occurrence of disease, the benefit of interacting and participating in that for personal good and global good. And then, of course, layering onto that the real-time, high-resolution environmental and socioeconomic measures, as illustrated in what's called the weather underground. Just demonstrating the variation and monitoring of weather across the planet is something that's very clear now. Yet we don't have that technology for access to healthcare, which is remarkable. And this is just a little story out of that World Bank article that highlights that what gets measured gets fixed. This is an example where they used some IoT real-time sensor data that was connected to water pumps. And in the situation where I had a mobile enabled data that measured whether the pump was broken or not versus just simply reported by humans, the baseline for repair dropped dramatically. And so the idea that we're sensing can really drive responsiveness, just like that urgency reaction to that Johns Hopkins website. And those paradigms, I think, will move us rapidly along that diagonal, no longer building something here for something over there, but realizing what's needed over there and working together. Beyond that, there's another level that comes with this computational and digitally enabled paradigm, is that computational predictions for investment in technology design. I had the good fortune of working with individuals like Mary Gospodarowicz and Rifat Tattoon and Daniel Roden on a large-scale modeling effort we did to understand what was the data-driven or evidence-based motivation for radiotherapy worldwide, and calculating the investment that was needed, and then measuring the return on that investment or calculating the return on that investment. And to me, it was quite a compelling thing to do. We had to do it for 184 countries worldwide, looking at the investment on a certain number of cancers. But it really made it clear, not just the ministers of health, but also ministers of finance, about what the return on investment. And I see more and more the data feeding these computational paradigms where it's very clear what the benefit of our action or the loss of our inaction will be moving forward. That same computational capacity is going deeper on developing new drugs. If you follow DeepMind, you'll have heard of AlphaFold 2. DeepMind just spun off a new drug company because they will be able to design new drugs much more efficiently than ever before with that kinds of technology. And there's a cool little figure on the bottom below. You can spend lots of time on YouTube if you want, watching about Boston Dynamics robotics, but fundamentally, the use of machine learning and AI will facilitate the much more rapid design of new prototypes. And we could see really interesting predictions of the benefit of an innovation on the impact and drive investment on that innovation moving forward. So kind of a computed impact of discovery and invention as a method of driving investment. And this is just really highlighted. Danielle Roden took the work that was done in the Global Task Force for Radiotherapy Worldwide, and then propagated it further, not just on the use of radiotherapy in the context of cervix cancer, but then folded in the vaccination arguments. And this demonstrated that you actually want to do it together, not as an or. So it kind of takes us away from these grossly simplified forced choice best buy arguments that we often hear in the global health context. This is just the last few slides, and we'll wrap up. I'm looking forward to the panel discussion. We're also seeing the healthcare as a service, and this is just a sort of a portmanteau on healthcare and software as a service. But we're very much seeing that access to services, if we see that connectivity develop, will change dramatically. And the use of AI-based approaches for diagnosis and prediction platforms, I'll highlight that a bit in a minute. They're using these technologies to reduce the latency in our ability to move expertise to different parts of the planet, decision support systems, and the development of new technologies that can be supported remotely, bypassing the need to recreate the entire paradigm that was developed in the developed nations. And of course, which I'm not going to spend much sure will be a topic during the discussion, was the acceleration of virtualized care paradigms. And we saw that this broke down many much traditional thinking around access to healthcare and the utility of virtualized connectivity between patients and providers. If you're really interested in talking a lot more about the role of artificial intelligence in global health, there's a really nice article in Science by Ahmed Hosni and his supervisor Hugo Ertz from Boston and Maastricht, and just highlighting the many different places we see AI impacting the global health challenge. And this was not just cancer, of course, but everything from the issues of access and workforce and equipment, bringing literacy, talent, managing regulation, from diagnostics to clinical support to population health, including management of health registries and epidemics. So it's a really nice overview of the many opportunities that come by and large by digitalization and computing. One project at MD Anderson that I'm involved in with Lawrence Court is the development of a radiation planning assistant. And what Lawrence has been doing is building an entire architecture that allows organizations from around the country upload CT data sets and have AI-based segmentation and determination of plans, and then those are returned back to clinics around the planet, where they have to go through a commissioning process before, of course, they would use that plan. But figuring that out, figuring out the regulatory issues around it, making sure the expertise are sufficient to use that information safely, that is really much the frontier as this connected world, reaching out on this diagonal to support more directly the needs for services worldwide. So just in closing, the local and global burden of cancer is massive and growing. This is just highlighted in the IR reports, up to 30.2 million cases per year by 2040. Technology will make it even more visible. I think we barely get a view on the burden. It's going to make it undeniable. It's going to make the result of our inaction predictable, because we can see what our intervention could do. We can model that out. And I think this is just an exciting new frontier that's data-driven and responsive, and through bi-directional connectivity on that diagonal, it will challenge the conventional paradigm of medical colonization. I look forward to the dialogue in the panel. Thanks for inviting. I'll come back to you, Fabio.
Okay. Oh, we're having some echo. Okay. Hello again, everyone. Hello again, everyone. I'm inspired and thrilled to start this panel discussion. Thanks, Dr. Jaffray, for your exceptional lecture, highlighting on topics such as technological growth, data flow, how data is transforming the healthcare landscape, how one disease has transformed the way we look and evaluate data, and finally on the power of AI for global health. The future looks promising, and innovation can play a role on promoting global oncology improvements. Thus, I would like to start this panel discussion by asking our panelists, what are the opportunities presented to us by emerging digital technologies towards accelerating the progress in cancer care globally? Would be great to see any real-world examples. So I will start by the order that I see on my screen. So I have first here Dr. Aggarwal. Would you mind giving your opinion?
Thanks, Fabio. I think there are a number of major challenges, and I think from a structural perspective, they relate to basic infrastructure, the workforce challenges, but also trying to ensure universal health coverage. But within cancer control specifically, I think there are three areas that it could have a dramatic effect. So I think, first of all, we know that the mortality to incidence rate globally is very variable, and that's related to late diagnosis. And I think we need fundamentally to see how we can traction digital technologies for stage migration, which will make a significant difference. Early diagnosis, more curative cases. Second of all, we know that for each 4-week delay in treatment, you increase your risk of mortality by 10%. Quicker treatments, not waiting. I've heard recently in parts of South Africa delays of 6 to 12 months for basic cancer treatment. each 4-week delay makes a significant impact. So second of all, quicker treatment. And I think third of all, we need to expand capacity. But expanding capacity and maintaining quality is always very difficult. So I can see digital technologies maintaining consistency of that treatment and the performance to reduce inequities. So I think those are 3 key areas, really.
Oh, very interesting. Thanks for your comments on 3 key topics. With that in mind, I would like to ask Dr. Lasebikan to present her view as well for us. Are you mute? It's still muted. Okay. Richard, you want to go ahead, Doctor, and give your opinion until we figure out the audio?
Sure.
Yeah, go ahead.
Well, before I do that, Dr. Jaffray, thank you for that. I am so excited about what the future holds. You said it may be optimistic. I don't think it is, and I think this is what we have to look forward to. I think it's really data-driven in as much as I think up until now, many clinical encounters we haven't reached the full potential, and we've had many missed opportunities for learning. Without engaging the web-based applications that we have and the technology at hand, without building up these databases, we really have missed opportunities up until this point. So I'm very excited about the future, and as much as, in other industries, we've seen it in Spotify, Netflix, and entertainment, Amazon and shopping. They've not only improved service delivery, but what it's done is consumer predictions. So I think from an oncology point of view, we're going to be able to see a very real movement in precision oncology, using data in proteomics, using data, molecular data, clinical data, patient-reported data, to start generating what I hope to see as a sort of a global connective consciousness of all our knowledge that can give us real-time clinical information as to what the best next move would be. From a surgical point of view, the amount of videos that are being shared around the world, eventually, hopefully, you can almost envisage a GPS-like mapping system to help me guide my next step in the move. And I really do believe that this is a very exciting frontier for precision oncology and the improvement of quality.
That's great. Thanks, Richard. Let's. You want to try again, Dr. Lasebikan? Your microphone is still showing muted, so we can't hear you. Yeah, we're having some technical issues here. So, Dr. Berlin, you wanna?
Yeah, I can probably. I'll piggyback on some examples. I think you wanted some concrete examples. So I agree with Ajay regarding our early diagnosis. I think capacity is the other big one, that either anticipating or arriving earlier in the diagnosis, or anticipating issues with our treatment. So on early diagnosis, there's certain companies, like one good example is Butterfly, which is a ultrasound for point of care that can be connected at mobile devices and has a collapsed price of like $2,000-3,000 compared to a multiple 6 figures or close to 6 figures, a full ultrasound diagnostic capacity. So I think obviously there is a risk with those technologies, and we can get trapped on performance, but they can be tremendous, I think, equalizers in terms of opening access to certain technologies that now are prohibitive in certain environments. I would say in capacity and responsiveness, some of the work that was mentioned around quality assurance of radiotherapy plans, or could be on the delivery of certain drugs, and automation in the planning of radiotherapy, or the QA or quality assurance of radiotherapy, is another area of potentially explosive growth. And the last point, perhaps, where touches a little bit what Richard said about multi-layered data, I think, is integrating clinical care with research. We tend to have these in separate buckets, and there's now this tendency to real-world evidence. I'm not saying that that's kind of a magic bullet, but I think having that capacity to elevate the clinical data and having these multiple sources of data integrated and loop back into the clinic in more rapid cycles. And I think that's what we learn from technology. The classic waterfall approach that you develop something and then you deploy it is obsolete. Is these rapid cycles of development and deployment that happen simultaneously. And I think we as a medical community could embrace some of that in trying to use technology as a lever to advance care.
Outstanding. Thanks for your comments. So I think now we'll be able to get Dr. Lasebikan to give her points as well.
Okay, can you hear me now?
Yes.
Okay, yeah, so I just wanted to say that coming from a region where we are, the workforce is very limited, you think that AI really has potential to really scale up patient accessibility to patient care. You know, it really has the opportunity to really democratize access to patient care. You know, I think during his presentation, he talked about patient-centered care. And for us, we see a big role in that area, considering that for us in Nigeria, where we have only 81 oncologists with a population of over 200 million, we see that playing a huge role in helping patients, you know, to get seen quicker. Like AJ said, you know, every 4-week delay makes a huge impact on the clinical outcome. So we see that playing a huge role there. And also in terms of helping again with clinical decision support, because, you know, again, because we're so few, there's a tendency for us to be really overworked. And then, you know, that has the potential to really help us to quickly make decisions that are based on the evidence, you know, even as regards patient care. And also when we talk about radiotherapy treatment planning, again, this is something that will help us to really cut down on the time it takes for the treatment planning. So I think there's really a strong for it, you know, in our region, yeah, especially as oncologists, and not just in treatment, you talked about a lot, but also along various aspects of the cancer continuum. Very effective for us in diagnosis. Even the ratio with the pathologist is also limited, you know, within the country and indeed within the Africa region. So there's a strong role within diagnosis, early detection strategies for parts of the country where we don't have less screening. Having this tool will perhaps serve to also help in terms of engage patients and really help them, you know, to know when to screen. And those that are even on treatment, again, I go back to treatment, but it also helps them to be able to track some of the side effects and also remind them of their appointments and really keep tab. So for us as practicing oncologists in Africa, it really poses a huge advantage for us, and it's something we're really looking forward to. But then, of course, there's a lot of caution too, because as some of the things that had already been talked about, data privacy, and really ensuring that some of these machine learning tools that are being developed are actually things that will be adaptable to our region, because we know that we can't really transpose what happens in the high income countries down to our own region. We really have to try to adapt it. So lots of things to be cautious about, even though we do see the great potential this has in really improving patient care, but then there's also need for caution and to tread, you know, very gently.
That's perfect. Yeah, thank you. And I would get I think it was a good first round, and I want to wrap up with David Jaffray on his points on the topic as well.
Yeah, this is great. I mean, I think it is a very exciting future, and as all the other panelists have commented, I think there's a huge opportunity to measure real burden. I think we completely underestimate the impact of the disease on the population, the stress, the lack of certainty in accessing services. I think technologies will let us measure that. And I think what's going to do is it's going to drive us towards the sort of paradigm that we're seeing when you're waiting for your FedEx package to arrive. You see it coming. And that kind of urgency, that kind of engagement, I think is extremely powerful. It will allow us to focus on the responsiveness of services, to AJ's point, the development of technologies that make sure we get patients in sooner, because we know the best intervention in cancer is early intervention. And so, I mean, there's a lot of examples where we could see, like, even AI technologies shortening all those gaps. And if we shorten up those gaps, then you get that responsiveness. It is worth engaging and responding and following up in the healthcare system. And I think that's a very positive feed forward cycle that the digital technologies will enable.
I really like the points, especially on the sense of urgency and how we can use like innovation and AI to help like decision, to help tracking, and to engage better with patients. So this first round of questions, now I want to make the discussion more fluid. So people feel free to jump in and comments on other comments. I would love to also, as we heard from Dr. David Jaffray, that we learned from other diseases, and we saw during the COVID-19 pandemic a rise on virtual care, and that empowering patients and potentially giving access, so digital health giving access for people living far away from big centers. How do we see virtual care? How are the barriers, and how we can expand access to a specialized care in many places in the world?
I'm happy to jump in on this one. I mean, I work in the United States now, and the barriers in the United States to access services across state lines were rescinded because of the pandemic. That transformed healthcare in the United States. And that's in a developed nation. Like, I think there's so much room for change enabled by services virtually in every jurisdiction in healthcare. And the pandemic kind of got us out of a rut. It was, competitive in its nature, restricting access for a variety of reasons. And I think we're going to see an expectation. I mean, no one wants to drive somewhere and pay for parking and all that. No one wants to do that. No one wants to travel far distances to access services. I think it's so critical in this responsiveness paradigm that I see coming to healthcare.
Yeah, I can probably chime in here. I think what the pandemic really did to some extent is demonstrate once again that we can digitize some of our existing processes. I don't like to call that transformation, to be frank, because being a clinician or a provider and a patient at the same time having an encounter through a screen obviously removes some barriers. It's more convenient. There's less transportation and wastage of time, but it's not truly transforming how we can scale up. You still need that provider with that patient one at a time instead of in front of each other in the room, in front of the computer or whatever device they're sitting in front of. So I think we need to think beyond that and say, okay, how can we empower patients to self-monitor? How can we put decision support system that allow patients to track their own disease? Does it really make sense a patient go every X number of months to their general practitioner to get renewal of a prescription for a hypertensive drug that they have been renewing for 8 years? So I think we need to question things a little bit deeper and say, okay, how can we use some technologies to streamline, scale up things, and be careful that some of the things that apply in certain environments and certain jurisdictions don't apply in others. So I'm not advocating that this should be applied in other environments, but perhaps those environments need to be helped to figure out what is the technology or the experience or the expertise that allow other environments to solve a similar problem and translate and adapt to their reality, because obviously the needs are different in Chile, where I was born, than in Canada or Israel, where I have practice, because the transportation is not a problem in Israel. You can get from one corner to the other in 2 hours drive. So the issues there are obviously different than the ones we encounter in other parts of the globe.
Did you? Yes, thanks, Fabio. I mean, just to add to Alej's point, I suppose with the pandemic, I mean, there's nothing like desperation for us to become innovative and to do those transformations that we want to do. But I think just sound a note of caution, I would say two things. I think the digital transformation did help some, but may have left others behind, and we need to see that. I mean, even in our clinics at the moment, we're probably seeing the reverse of the people who presented late, partially because of the accessibility to primary care in particular. And I think second of all, we did notice the pressure point. So I think digital technology has to go hand in hand, and it's a useful example with the capacity building. You know, at the end of the day, the pressure point is someone has to take a biopsy, someone has to do the operation, someone has to sign off the treatment plan. So it does come down to workforce and that oversight. So I think the transformation can improve the accessibility elements, and we have to carefully define where digital healthcare fits within the existing paradigm. It's not going to be a replacement, but it's adjunctive, and it can hopefully improve the quality and consistency. So I'd probably take that tack.
Thanks, Ajay. I must just comment. I really enjoy how you bring up these sort of words of caution amongst this optimism. And I don't know if anybody, the references that Fabio kindly shared, and I really enjoyed reading your article, the Beware of the Hype of the AI-based healthcare in low to middle income countries, where you speak of comments like a technological colonialism. We have the solution and just need to be allowed to make the difference. I could really relate to a lot of that. I think what you said so nicely, and I think when we look at what COVID and the pivot that's been, is just really trying to understand workflows. So wherever that workflow is in that local community, at a hospital level, at an individual provider level, and bigger at a provincial level, at an international level, if you understand the workflow that needs to happen, that can be automated within these technological potential that we have. We did, for example, as COVID started, and there was advice on how do you advise somebody who's high risk and immunocompromised versus somebody who's had a contact versus sometimes who's got early symptoms. You can silo these and have very much signals that you can direct patients through automatic logic peripherally. And we know that this will improve the service delivery if we understand the workflow at whatever environment that we're in. So again, I think it's to be cautioned, but overarching opportunity.
Yeah, so I just wanted to add that for us over here in my country, with the COVID, it helped us to see that there was really an open chance for us to flourish even with digitalization, because
we lost your audio again.
Right on, because as well.
These are the sort of technological glitches that AJ is trying to caution us against.
Yeah, that's true. And in meantime, I knew David, you would like to do some comments, and also there was a question on the Q&A saying that Dr. Gospodarovic asking you to talk a little about challenges in data sharing, issue of public trust, and ways to accelerate adoptions of digitalizations by the health sector. And I think goes well with this discussion, as we're saying about streamlined processes, scaling up, data power. So it would be great to have some thoughts on that as well.
Yeah, I just wanted to make the point that as we try to export our standards in developed nations to other nations, there are people who are not getting access to services and they need them. That's that paradigm on the diagonal. virtual care will allow a lot larger number of people to get access to services. Maybe the services aren't quite as good as we believe them to be in developed nations. And honestly, I think we're not the ones that should be making that choice. And so that global optimization on the use of technology, that's what that diagonal is. And so I just want to push back at Ajay a little bit on here, because I know it's a cautionary component, but it's us holding to what we think is a developed standard. And I think we're letting a lot of impact go. And so I think this is this healthy debate and moving along that diagonal I'd love to get into. So maybe I'll throw it back at Ajay a bit on these.
No, do. I think it's interesting. I haven't said anything, and everyone's already taken my position. It's especially when I work with Lawrence on the RPA. But I think the point in question is one that on average, a technology takes 15 to 17 years to embed. There's two often failures of technology. One is of evidence. What's the value added? Is it performance? Is it cost? Is it workflow and speed? But then there's an implementation science question. I think we often don't get that correct. And it's actually just a bit more conceptual thinking and an overriding thing of actually how is that technology going to integrate? So I think as part of evaluation, it needs to be key to that. So is the technology a simple or a complex? And we have to deal with that complexity, not necessarily by dumbing it down, but embracing it and seeing what the interactions, it's the social technical system. So how the technology interacts with people, patients, organizations, industry. And that requires an understanding of what the barriers and facilitators are. I think qualitative work's great for that. Understanding with respect to the technology, actually, is there money to set it up? Is there money to maintain it? Is there interoperability? Is there good internet access? Can patients use it? Do doctors feel threatened by the technology itself? Is there regulatory approval, professional bodies? So there are many factors which result in a technology that has huge potential, and then suddenly it just doesn't work. And there are also the other pressure points of, we can get people quicker through planning, but actually if there are not enough machines to deliver treatment, then where do you go? So I think it's not so much cautionary as just make sure that we keep thinking and use the available disciplines such as implementation science to get the right technology in the right place and actually deliver the excellence in care we want to globally.
I'm not gonna poke back, but just a thought that emerged when we say this. We have this deceiving perception that the status quo is always kind of better than when something disrupts. And sometimes we could argue that disruption, the only thing it made was make the problem more evident. So it's not a new problem. The problem was already there. There is inequality in our globe, and there's people who don't have access to healthcare. The fact that you introduce virtual care and there's still people without access doesn't mean that the problem is new. It just means that you perhaps made the problem more evident to your eyes, and then you have to work to kind of fix it. I'm not saying that it's not a problem, but there's these deceiving perception that the status quo is safer and error-free compared to the change, which always comes packaged with some disturbance and uncertainties.
I mean, the disruption is absolutely critical, isn't it? But it's just thinking ahead, isn't it? It's just how we can get those how we can get those leadership and the stakeholders involved. So I'm completely on board with that.
Just to heighten another reference that was kindly shared by. Sorry, go for it. Dr. Lasebikan?
Can you hear me?
Yeah.
Yes. So I just wanted to say that these are some of the things that we really need to think about when we're talking about really pushing forward digital technology and AI with all the internet issues that I've been having. So proper infrastructure obviously is something that we need to think about if we want to really implement this, because these things will always happen, short bandwidth and all of that. So even though we think that there might be a great use for it, in terms of speeding up the process, but infrastructure is something we really need to think about, and also acceptability. I was trying to share that even during the COVID era, when it became clear with the lockdowns that patients really had to have access to care. So it actually flourished and blossomed. It was now a new way of thinking, because they just needed to have access to their care. But even as they did so, it opened up a new world for us, and that, you know, we're now able to think about it more broadly to see how we can deploy these technologies and help, you know, with getting patients to be seen. Ultimately, I think that as we try to move forward with this, we really have to, as AJ implement, we really need to involve implementation science into this and really try to bring technologies that are locally relevant and that will actually speak to the disease burden and the health systems infrastructure that are available. Otherwise, we may not really be doing as much as we intend, even when we start off.
That's great. Richard, you want to keep going? You were about to comment as well.
No, that's good, Fabio. Thank you. I think it's been said. All good.
Okay, so we're getting close to our last 5 minutes of the session, and we have touching points like how to evaluate technology, implementation, interactions, building equity, access with equity, and being realistic. With that all said, I would like to see your vision on how we can scale up new technologies by building capacity, training the next generation, and also making sure that there is effort for building infrastructure when where is needed.
I may start a comment just to say again a reference by Ynoe et al., who you kindly shared, transparency and reproducibility. I think there's a lot of key points in that. I think in this environment where there is hesitancy and different contextual environments, to be able to measure, you know, bring it back to the basics is how do we measure scientific progress? Comments made where you first scrutinize the results. They need to be transparent. They need to be open. You need to try to reproduce the results and reproduce them that are contextually based and designed. So why would we do anything different in our own hands or whatever? And then build and scale with those new learnings and be transparent about that. And I think that would be go a long way. You know, we didn't touch on as many real world examples that we could have, but there have been already a lot of real world examples that would be great to see if they could be reproduced in other places to start getting some traction.
I mean, I'm happy to jump in. I think the example we've seen with Dr. Lasebikan is a perfect illustration. Connectivity and access to information in a bidirectional way, not just to drawing from nations to developing nations, but rather hearing back about the current status, I think is really, really important. I'm convinced it's the flow of data that will shape society and healthcare systems in the future. And so if we invest in connectivity, I think it may not seem like an immediate benefit in healthcare, but it is such a key platform, I think, to address the asymmetry, the biases, the lack of understanding of the need. And so I'm keen on connectivity. That's where I think we should be going.
I know I've just commented, but I just had to also, with regards to, you know, cost is one that's always flagged. If we really be able to work on the data and practice more predictive medicine, as opposed to, you know, preventative medicine used to be the new hype, but prediction is now better than cure, really. So the cost, I mean, there's been figures said that AI the data and the analytics and the predictability of the data that we could have available in the US alone will save us about $300 to $450 billion annually. So if you start building this infrastructure and be able to practice predictive medicine, I think the cost is not the immediate hurdle here. And I agree, building that infrastructure and connectivity will be a really big savings in the long run.
Yeah, I think, let me add, I think is oh, sorry, go ahead,
like
please.
To add. Okay, I just wanted to bounce off what he said about precision medicine. I think that even as we look at, you know, developing AI and a lot of machine learning, it will be important for data to also from Africa be, you know, to be to the system so as to prevent bias, create that diversity that is currently limited even in most of the solutions that are being provided. When you want to deploy to the African countries, for instance, as a solution, there really would be a lot of bias because we don't have a lot of data coming up from Africa to be able to inform the machine learning that is currently undergoing. Yeah.
So if I can add, I think we've mentioned a few things about data equity and the trust on the data and the transparency. I think the true value of the data, it's not on the flow of the data, and I'll take the guts here to disagree with David, but I think the true value of the data comes when data is used and reused for different purposes. And that is the value proposition of data, because that forces you to have the data in a shape that it's usable, understandable, people can access it, can transfer it and everything. So if the focus is on using data, then you naturally will figure out how to have data that is reliable, that it's pertinent to the problem that you have to face or tackle, and that at the end of the use of that data, the data is enriched in conditions that can be reused for a different problem. So if we focus on using the data, I think we can get way more meaningful advancements.
Can I respond to that? Very briefly.
We have 2 minutes.
The thing is that the data is available is what gets used. And data that gets used gives insight and drives investment. If there's no data coming out of Africa, there's no analysis, there's no insight, there's no investment. So I think data really does carve the society. Where it flows from will dictate where investment goes. And we have to somehow address that. Good to converse on, Ali.
Fabio, it'll just be a quick minute.
Yeah,
I know you have to just
one,
wrap up. So I think this is the future. Systems level, we need to look at data governance frameworks, and a number are coming about. We need to look at privacy laws. We need to understand who owns the data and how we could invest in private-public partnerships to get the best use of it. So we infrastructure build, but also we also need to ask the right questions of the data. So that involves being needs-led, co-development, and understanding how we can evaluate with an implementation science framework. I also think where we can use open source is good, trying to avoid maybe vendor capture and being able to have that interoperability can be helpful as well as training. I think in a new digital world, we all need training. Our junior faculty need training to be able to use this as part of our clinical algorithm and that predictive technology if it comes through and is shown to be effective. Thank you.
That's fantastic. I would like to thanks everyone for this great session and great discussion. And I need to close the session so we move to the next one on time. So thanks everyone. Have a good day. Thank you.
Everybody.
Bye. Thank you.